a summer camp, the CNIW summer camp. I'm also a student member of the CNIW board of directors, and I'm delighted to be your host for this seminar. I'd like to welcome Dr. Gillian Kolla tonight as our guest speaker. Dr. Kolla, it's wonderful to have you here today. So during this session, she'll be discussing public health research in contentious times and various important controversial topics, including harm reduction, substance use, and the Canadian overdose crisis. These are all issues that are incredibly relevant in our society today. So I would like to take some time before we start to introduce Dr. Kolla to everyone. She's currently an assistant professor of population health and applied health sciences at Memorial University's Faculty of Medicine. And as a postdoctoral researcher, she holds a PhD and a Master of Public Health from U of T. Dr. Kolla has an extensive background in public research, and she's been doing some fantastic work around harm reduction strategies, like evaluating safer supply programs in BC and Ontario, where the aim is to provide prescribed medications as a safer alternative to the toxic and illegal drug supply that individuals at risk of overdose tend to reach for. She also looks into how drug policies impact the effectiveness of health and social services, particularly in addressing the barriers faced by marginalized groups like drug users and those experiencing homelessness. And what's really cool about Dr. Kolla's work is that she doesn't just stick to the lab. She's all about getting out into the community, working with people who are actually living these experiences and finding out what barriers they're facing when it comes to accessing healthcare and social services to really understand and tackle these challenges. So tonight she's going to talk to you about, first of all, what exactly is driving the overdose crisis. Number two, what interventions and drug policy responses are out there. And lastly, the obstacles that are getting in the way of an effective response. So without further ado, let's hear from Dr. Gillian Kolla.
Perfect. Thank you so much, Lisa. That was a great introduction. And you did such a good summary of my presentation that I could probably jump right in. And just so I could confirm, we're together for about, for how long tonight?
About, you can talk about 30 to 45 minutes, and then we have 15 minutes for question and answer.
Okay, perfect. So I'll go for about 45 minutes, then we'll do questions. There's also a couple moments during the presentation that I'll stop along the way. Just so if you've got any questions, you can feel free to put them in the chat so that we don't have to hold everything to the end. But I'm going to get started. So as Lisa said, I'm going to talk to you today about a number of different interventions that have been put into place to try to address the overdose crisis in Canada that we're facing. I'm going to focus quite a bit on harm reduction interventions, but I'm going to talk a little bit more about the whole spectrum of interventions. But I'm going to start by actually talking a little bit about the overdose crisis and what brought us here, and more importantly, some of the myths about the overdose crisis that are so pervasive that they're accepted very, very broadly, but don't actually characterize the current crisis that we're facing and are getting in the way of a response, an adequate response. And so just to give you an idea about the crisis that we're facing in Canada from the drug toxicity overdose crisis, since January of 2016, there have been over 40,000 deaths. The data currently is only up to June of 2023. In 2021, which is the worst year on record and which was the year that I have on the screen here, there was just over 8,000 deaths in Canada. We have about the same number of deaths for 2022, but all the data from all the different provinces and territories aren't quite in yet. Currently, there is about 22 people dying every day from overdose in Canada, which makes this a substantial public health issue and public health threat. And just to give you an idea around how it relates to other causes of death that we see, here's some data in British Columbia. I was doing my postdoctoral fellowship in British Columbia over the last 3 years. So I'm going to be showing you a lot of data from BC and Ontario, Ontario being the largest province in Canada, the place where I did my PhD research, and then BC, one of the provinces that's been the hardest hit by the crisis. And you can see here that unregulated drug-related deaths have actually shot up significantly starting in about 2015. And then again is starting in around 2020 with the COVID pandemic. And this absolutely dwarfs right now other what quote unquote unnatural causes of death in British Columbia, including homicides, motor vehicle accidents, prescription drug related deaths. That's that very low blue colored line at the bottom, and suicide. And so really unregulated drug deaths right now, so deaths from people taking drugs from the street markets are currently dwarfing all of these other causes of death. And right from the get-go, I want to talk about some of the myths around drug-related deaths. So we hear a lot about the prescription opioid crisis and prescribed opioids being the problem. And here is a graph of some data from deaths from prescribed opioids in Ontario, starting in 2004 and going until 2015. So just over 10 years of death before the unregulated drug supply shifted to fentanyl. And you can see that while there was a slight increase and something to be concerned about as public health researchers from prescribed opioid-related deaths, it was still fairly low, peaking at about 600 in about 2015. And if we think about the contribution of overprescribing of prescribed opioids to the current crisis, again, looking at Ontario data, starting in 2013, when there was a lot of concern about that increase in deaths that you just saw in the previous slide, people started to really diminish the number and volume of prescriptions that were happening, which meant that fewer people were getting prescriptions, which is the graph on the left. And then on the right, you can see actually that depending on the dose, we saw, depending on the dose that people were getting, the same decrease that was happening across the board. And so if the problem was actually overprescribing of opioids from medical sources, then you would expect that this strong diminishment that you saw starting again in around 2015, 2016 would have an impact on the deaths that we're seeing from opioids. Unfortunately, that is not at all what happened. You can see right, I don't know actually if you can see my clicker, but you can see right here, laser pointer, let's try that. Right here in 2013 is where we started to actually have that diminishment. But instead we see the opposite effect where as the number of prescriptions was going down, the number of deaths were actually skyrocketing in Ontario. And one of the reasons for that is that if we actually look at the type of opioid that was found to be responsible and present at death, what we see is that actually prescribed opioids, these are the red and this purple lines at the bottom, stayed very, very stable. What ended up happening and what ended up driving the crisis of overdose deaths that we're seeing is in fact fentanyl from unregulated street markets. And what we started to see starting in 2015 in BC, a little bit later, as you can see around 2016 in Ontario, was we started to see fentanyl take over unregulated or street markets and displace heroin completely. And that's what has caused this crisis of drug-related deaths that we're seeing right now. It's not actually prescribed opioids that are the problem. And again, here is another graph, and that's showing how unregulated fentanyl right now is responsible for 89% of all deaths in Ontario, 87% of deaths in BC. And again, this right now is the crisis that we're facing. The prescribed opioids, even going back quite far, we haven't managed to actually make a dent in the number of people who are dying from prescribed opioids, either through increases in prescribing that happened in the early 2000s. You can see a small blip here of oxycodone related overdoses increasing, but overall it's been actually very stable compared to the drug toxicity crisis powered by fentanyl. And so really, this began, as I said, in Ontario, starting in about 2016. And there's been quite a bit of discussion within public health circles around drug policy about how one of the issues that's being faced here is that drug prohibition actually leads and creates perverse incentives for more dangerous drugs to becoming more dangerous and more concentrated drugs to be coming into the unregulated street supply. And this is actually a phenomenon that we first saw during alcohol prohibition. Prior to prohibition in the United States, the alcohols that were the most popular among the population were actually the lower concentration by volume alcohols, so things like beer and wine. But during Prohibition, there was actually this move towards more potent and more concentrated alcohols like vodkas, rums, and whiskeys, because those have a higher potency in a smaller amount. So if you're going to be a smuggler who's smuggling alcohol, in that case, it was primarily from Canada into the US, rather than smuggle barrels of beer, it makes more sense to actually smuggle a more potent substance like whiskey that's more concentrated, because you can get basically more bang for your buck. You can get more across the border in a smaller concentrated volume. The argument is that that's a very similar thing that's happening here with the transition we've seen in the unregulated drug market from heroin previously to fentanyl now. Fentanyl is much more concentrated, much more potent, and so you can bring in smaller quantities and still actually have the similar potency that you were seeing when you were bringing in bringing in heroin. And so really, I think that one of the things that we've had to grapple with within public health is just how much fentanyl has changed the status quo in terms of our drug policy and our responses to the overdose crisis. And I think it's just important to note very, very quickly that this is not a crisis of opioids alone. Across the country, we're actually seeing what we often call polysubstance related deaths, which is when you see multiple different substances involved in drug-related deaths. This is something that actually increased quite substantially during the pandemic, during the COVID pandemic. So if we look at the pre-2020 data and compare it to the post-2020 data, we've seen in particular a massive increase in benzodiazepines. So these are drugs that are used and prescribed to treat anxiety and for sedation. The ones that we're seeing appearing in the unregulated drug supply are not drugs that are actually, or benzodiazepines that are usually prescribed in Canada. In fact, none of these are regulated for use in Canada. These are all again being added to the unregulated drug supply. We're also seeing an increase in the amount of stimulants that are being found in postmortem toxicology, including both cocaine and methamphetamine, while alcohol has remained fairly stable. And so when we're thinking about addressing this crisis, we have to realize that this is not just a crisis of opioids, but a crisis of multiple different drugs. And going forward. And also the other major change that we've actually seen in terms of the ways in which people are using drugs is a shift to smoking fentanyl. So heroin could be smoked and was often smoked by people when it was the opioid that was available on the street. However, fentanyl is much more potent and actually easier to smoke. And so we've actually seen a massive shift and a massive change in the way in which people are consuming street-acquired opioids like fentanyl, a major shift towards smoking them rather than injecting them, which has interesting implications for public health, because as public health practitioners, we've often been really concerned about the injection of drugs because of the risk of transmission of bloodborne diseases like HIV and hepatitis C. With the shift towards smoking, there's less of a risk of those infectious diseases transmitting. Unfortunately, also smoking is still very, very involved in overdoses. And you can see here that there's been a very strong increase in the amount of when they are doing investigations post-mortem. There's a very, very strong shift to evidence of inhalation equipment at different scenes that coroners are investigating in Ontario. The one last thing that I'll say, and then I'll pause right after this slide to just take to see if there's any questions so far. The one thing that's important to note is that there's a substantial regional variation in overdose deaths across the country. We're not seeing the same patterns of deaths in the entire country. BC and Alberta's death numbers have actually increased a little bit over this slide. This is data from 2021. Unfortunately, Alberta has had very bad increases in overdoses in the last 2 years. Saskatchewan has as well. But we've seen in the Western provinces a much, much higher rate per 100,000 population of overdose deaths. Ontario is around the median for the country. And then the Eastern provinces, starting with Quebec, have actually been somewhat protected against fentanyl infiltrating into the unregulated drug supply. This is unfortunately changing in the last 2 years, where there has been starting, particularly in Quebec and in New Brunswick and Nova Scotia, there's been starting to see increases in fentanyl-related overdose deaths. So I think, unfortunately, that this is just a matter of time. And I always feel a little bit like the canary in the coal mine when I'm doing presentations in the Eastern Canada and the Atlantic provinces, trying to tell people that it's now is the time to get ready, that we can't just pretend that this number is going to stay that way forever. 5 per 100,000 population was actually Ontario's overdose rate up until about 2014, 2015, before fentanyl came into the drug supply. And so this is really, I think, a moment of caution and a moment where some provinces have a chance to prepare and learn from the experiences in other provinces. And so really quickly, I'm just going to pause and see if there's any questions. And I actually can't see the chat. I'm trying to find it really quickly. And so if you have a question, could you just pipe up really quickly, put on your mic and ask? I'm just going to wait in uncomfortable silence for 1 more minute. Okay, I'm going to assume that there's no questions then and keep on going. So in the next section, we're going to talk a little bit about some of the responses that have been proposed to the overdose crisis. And here, these fall into a couple of big baskets. The first is one that actually focuses on the idea that prescribed opioids and overprescribing was driving the crisis. And so these responses very much focus on deprescribing opioid medications to people who had been receiving prescriptions, as well as prescription drug monitoring programs, which is programs that monitor the number of pharmaceutical prescriptions that are given out and the number of people who are getting them. Drug rescheduling, which involves taking particularly high dose opioid formulations off the market, as well as reformulation. And here it's often reformulation into opioid formulations that are more difficult to inject. The second basket is treatment approaches. And we have to be careful when we talk about treatment, because treatment tends to be used as somewhat of a catch-all term. There's very, very strong evidence for opioid agonist treatments in the treatment of opioid use disorder. However, some of the other forms of treatment that are often quite popular, like NA, Narcotics Anonymous, those kind of types of orientations, don't have a particularly strong evidence base for them. And then the next set of responses are often what are described as the harm reduction responses. So these are responses that, rather than focusing on getting people to stop using unregulated drugs, they provide services and supports to people in the understanding that a lot of people, despite knowing that the opioid supply is very dangerous and that there is treatment options out there, will choose to use the unregulated drugs regardless, and that they should have access to different supports in order to make it safer for them to be using the unregulated drug supply. And so the first thing that I just want to highlight is this quite interesting paper that's a couple of years old now, that was published in the American Journal of Public Health. And what was lovely about this paper is it was actually a modeling exercise where they looked at some of the major interventions to try to address the overdose crisis and see what the impacts of these interventions would be on mortality. Now, this is a very busy slide, so just hang with me here because I'm going to break it down for you. Again, again, it breaks down into prescribing and drug rescheduling, and PMPs or prescription monitoring programs and drug reformulation. So all of these top interventions are the ones that focus on the pharmaceuticals and reducing the amount of opioids that people are being prescribed or transitioning them to other medications or rescheduling them. And so these are the interventions that actually, if you look at chronic pain prescribing as just one example here, you can see that by reducing the number of people who are receiving a prescription for an opioid prescription for chronic pain, you reduce the number of deaths from prescribed opioids. However, even back in 2018, it predicted that this was going to increase the number of deaths from heroin, from people themselves when they have their prescription taken away, that they transition into the unregulated market, that at that point was heroin. And we couldn't, I don't think, have foreseen that fentanyl was going to be on the horizon and coming. And they also looked at drug rescheduling. You see the same phenomenon where it reduces the number of deaths from opioid pills, but it increases the number of heroin deaths. The same from prescription monitoring programs. Here, it's an even more stark impact. The same from drug reformulation. So all of these interventions are things that are actually leading to an increase in the number of total deaths. Now, if we look at the harm reduction interventions, these are the ones that actually reduce the number of opioid-related deaths in both of the scenarios. And this was interesting because this was an early paper that I think, frankly, underestimated the number of deaths that were going to happen because they didn't foresee the transition from the heroin supply to fentanyl. But it was giving really strong evidence even early on that some of these deprescribing and opioid-focused or prescription opioid-focused interventions were not going to have the impact that some had hoped, and that it was going to be the harm reduction interventions that would instead actually save lives. Now, this is an interesting, something very similar was actually reproduced in BC, but using data that happened in 2016 and 2017. And if you remember the curves from BC, this is when fentanyl really came into the unregulated market very, very strongly in British Columbia. And they also modeled the impact of 3 different interventions only. So they didn't look at the prescribing interventions. They only looked at treatment in terms of OAT, which is opioid agonist treatment. Then they looked at OPS or overdose prevention sites or supervised consumption sites. So one of the harm reduction interventions, as well as THN, is take-home naloxone. So this is distributing naloxone, which is an opioid antidote, very widely in communities, which wasn't available widely prior to 2015. And what they estimated was that even though there was just over 2,000 deaths in British Columbia in the period under study, which was from 2016 until 2017, they estimated that in fact, just over 3,000 deaths were averted or reduced or prevented by the harm reduction interventions. So again, we have modeling data from both BC as well as in the US showing the impact that harm reduction interventions have on reducing the number of deaths from using drugs from the unregulated market. Now, I'm going to spend some time in the next little while talking about one particular harm reduction intervention, which is supervised consumption sites. Now, supervised consumption sites might actually become a big hot button issue again in the next 2 days because Ontario is actually poised to make a very, very substantial announcement in the next 2 days around supervised consumption sites. But what they are is they are a harm reduction intervention, which actually provides a place in an indoor setting for people to consume drugs that they've obtained outside of the sites under supervision of trained personnel. So supervised consumption sites don't actually provide people with any drugs. People have to bring their own drugs into the sites, and then sites apply for an exemption from our federal regulator, Health Canada, for an exemption from the criminal code in order to be able to offer this service. But unfortunately, the federal government actually just provides the exemption to the criminal code. They don't provide any funding to actually offer these services. And so then once an organization has received an exemption from the federal government, they have to go to their provincial or territorial health ministry to apply for funding for those sites. And we've unfortunately seen that several provinces, notably Saskatchewan and in some sites in Alberta and Ontario as well, have declined to actually provide funding for organizations that have actually obtained the exemption to operate a site from Health Canada. Now, the overall goals of these sites are to reduce some of the public nuisances associated with public drug use. So the thought behind it is that most people don't actually want to be using drugs in a public space. They would prefer to be doing it in a private place where they're not worried about police, where they're not worried about other people coming by while they're injecting. And so the supervised consumption sites, you open them up and people will rather use those than use in public. They also have a really, really strong evidence base showing that the use of supervised consumption sites reduces the transmission of HIV in particular, as well as hepatitis C and hepatitis B. They reduce overdose deaths from making sure that if a person does overdose, there's trained personnel available to intervene immediately. And they also have really strong evidence showing that they improve access to health and social services and improve access to treatment because the staff who are there are available to provide referrals and resources for people who want them. Again, there's been very, very strong evidence. I should note here that there's been supervised consumption sites. We're coming up to about 40 years of having supervised consumption sites, first in Europe and Switzerland, and then now we have them in multiple countries and continents around the world. They very much attract people who are experiencing some of the most problematic patterns of substance use. So some of the people who are what we call high-intensity drug users, who are using the most frequently at the highest risk for negative health outcomes, including HIV, overdose, and public injecting, that in the areas where sites are put in place, that they reduce the amount of public injecting, that they reduce mortality from overdose. And there's very mixed evidence on their impacts on public disorder. In both Vancouver and in Sydney, Australia, after they were implemented, there was no increases in different criminal code violations like theft, robberies, vehicle break-ins, and assaults in the areas around the sites after they were opened. In Europe, they didn't do as much of a systematic study, but there's been some reports of increased drug dealing and petty crime. And this has actually been a major factor. And a major, something that's been getting a lot of press in Canada recently is the idea that supervised consumption sites are contributing to public drug use and public disorder. And I'll talk about that a little bit later. Interestingly, there's also been some really, really strong cost effectiveness work that's been done, not just on Insight in Vancouver, which is the data that's shown there, but also on some of the sites in Europe and Australia, showing that these sites do save healthcare system costs, primarily from the number of cases of HIV that are averted, as well as from deaths. And the biggest issue that's often identified in the literature is low coverage, that there's very, very few sites that are available and that they often don't meet the need within the community. So worldwide, there's been more than 90 sites in cities in countries across Europe. In North America, there's now sites in the US, as well as in Mexico and in Australia. And in the Canadian case in particular, the first site in Canada is over 20 years old. In fact, it was 20 years last year that Insight opened the first sanctioned site in Canada. The Dr. Peters Centre, which is an HIV specialty hospital in Vancouver, had actually integrated supervised injection into its model of care the year before, quietly, without seeking an exemption. And then in something that got a lot of news media coverage, there was an attempt in 2008 to force Insight to close by the then Harper Conservative government, who were in power federally, that led to a Supreme Court challenge, and that in 2012, the Supreme Court of Canada actually ruled that closing Insight would be a violation of the Charter of Rights and Freedoms of supervised consumption site clients. So since then, you'd think that there was a Supreme Court ruling that happened and that led to increased sites opening. In fact, we didn't have any new sites open till 2016. So even 4 years after the Insight case was challenged, or was settled by the Supreme Court. And part of this was because after the Insight decision, a very burdensome application process was put in place to get a federal exemption. And despite a crisis of rapidly escalating overdose deaths, so if you remember, we started to see in Vancouver in BC in 2015, fentanyl coming into the drug supply. There was actually no movement to open up new sites until a group of activists opened an unsanctioned overdose prevention site. And an overdose prevention site is basically a very bare bones model of a supervised consumption site. There wasn't any movement to open up any new sites until activists started opening up overdose prevention sites. And you can see the one that was opened by Anne Livingston and Sarah Blythe. That's the two women that you can see there, opening up an OPS in Vancouver in an alleyway in 2016 in order to try to address the escalating number of overdose deaths. This actually set off a very quick movement of having multiple supervised consumption sites and overdose prevention sites opening starting in 2017. Including in Ontario. So in the summer of 2017, and at this time I was living and working in Toronto, and it was really at the kind of right at the beginning of 2017 that we started to see a shift in the drug market, more fentanyl coming in, many more overdoses happening. And in fact, there was 3 organizations in Toronto Public Health and 2 community health centers that had gone through the very long federal approval process and had actually gotten the exemptions from the federal government to open up. However, the provincial government, at the time a Liberal government, was stalling funding for these sites. And so the Toronto Overdose Prevention Society opened up an unsanctioned overdose prevention site in August of 2017 in tents in a park. You can see here. And this was very much a community-led initiative to try to save people's lives during a crisis. The Toronto Overdose Prevention Society, when they opened this site, and I was one of the people who was coordinating the site at the time, it was all volunteer operated. There was no official approvals. And we actually ran in the park for 11 months before being funded, seeing over 9,000 visits to the injection tent, so over 9,000 injections. And there was 251 overdoses that happened in that time, all of which people survived. And so it was very much a putting into proof of concept that a volunteer operated overdose prevention site in a park could be put in place very easily and save people's lives. What this led to very quickly, you'll remember that I said that there had been 3 organizations that had federal exemptions, but no funding agreements from the province yet. So in the week after the OPS was opened in the park in downtown Toronto, funding agreements were actually signed with the 3 sites by the province. And in fact, just 2 weeks after the OPS was opened in a park, an interim supervised consumption site was opened by Toronto Public Health. So they quickly got one open. And here you can see pictures on the left of Toronto Public Health's final open overdose prevention or a supervised consumption site when it opened, as well as one of the ones at a community health center on the right. And so there was very quick movement because of this movement of activists to open up the sites. And so the overdose prevention site in Ontario actually led to a lot of movement quickly. In January of 2018, the province put together actually a working group that announced a framework for opening overdose prevention sites across the province, where people were going to go through interested organizations could go through a provincial application process and get very quickly 3 or 6 months exemptions with funding in order to open up sites. Now, these were meant to be bare bones sites where basically if you had an organization that was currently providing services to people who use drugs, you could, if you had a room available, a couple of stainless steel tables, some chairs, and naloxone kits and oxygen, you could open up a site very quickly. And they were really, really meant to target organizations that were currently providing services. And so they could do so within existing infrastructure. It was under this model that the Moss Park overdose prevention site was funded and moved inside in July of 2018, as I mentioned, about 11 months after having opened in the park in tents. And within just 1 year, so 1 year of when the tents were opened in Moss Park in Toronto and the summer of 2018, there was 18 overdose prevention sites in the province that had been opened or approved. Now, unfortunately, at that point, the summer of 2018 is when the Conservative government in Ontario came into effect. And the Premier of Ontario, Doug Ford, was very, very vocal during the election campaign and after being elected about how opposed he was to supervised injection sites, despite the evidence. And so when he came into office in the summer of 2018, he ordered a review of the evidence on supervised consumption sites. And in essence, what happened in Ontario was a rebranding of the overdose prevention site model to a new model called the Consumption and Treatment Services model. And the Conservatives put in place a cap of 21 sites across the province. And so if you'll allow me to pull out my crystal ball for 1 second, I mentioned very early on in this presentation that we're likely to see an announcement in Ontario this week around supervised consumption sites. I think what is likely to happen is one of two things. There's a chance that the Conservatives will pull the plug on supervised consumption sites in Ontario altogether and pull all funding. The second option, and one that I think is more likely to happen, is they might actually just rebrand the sites again to something like a health hub, and that we'll just have a new alphabet soup acronym name for services that have been in place for a long time, rather than any new initiatives to try to save lives in the middle of an increasing and a very, very continuing awful overdose crisis. And so it'll be interesting to actually see, as somebody who has been through this once before with the Conservative government in 2018, I'm interested to see what's going to happen later this week and how the Conservatives reposition themselves 6 years after they did this first evidence review and rebranding, because they've been in an evidence review for the last little while. And again, this is speaking to that. Again, this has been an issue. Supervised consumption sites remain incredibly contentious despite the evidence. And again, as I'm going to say, the very strong public health evidence that they are very effective ways, not only of saving people's lives when it comes to overdose, but in connecting people to a broader array of health and social services, as well as to treatment. In fact, since 2018, when the Ford government came into place, there's only been 3 new sites opened across the province. And in one of the phenomenons in Ontario is that the northern parts of the province are actually the hardest hit. So areas like Thunder Bay, Sudbury, Timmins, Sault Ste. Marie. And these are places that have been trying to open supervised consumption sites, have been unable to do so under the current government in Ontario. And in the case of Sudbury and Timmins, they actually managed to open sites with local public health funding, hoping, and having gotten a federal exemption, hoping that the Ontario government, once they saw the site was in operation and saving lives, would then come through with provincial funding. In both cases, in Sudbury and Timmins, as well as in Windsor, the provincial government declined to fund these sites that were being funded by local public health, and they had to close, which, especially in places like Sudbury and Timmins, with rates of death that are twice the provincial average, is absolutely just devastating. We've seen this before in Alberta after the Conservatives came into power in 2019. They also had a review of the supervised consumption sites that were opened between 2017 and 2019 under the previous NDP government. So Alberta had seen 8 supervised consumption sites opened in that period. They had another evidence review, and they released a report in 2020 that was widely decried as being very unscientific. In August of 2020, this resulted in funding being pulled from the Lethbridge supervised consumption site, which was actually the busiest site in North America. It was also the first site in Canada to offer supervised smoking within the site. And in 2021, the Boyle Street supervised consumption site in Edmonton was also forced to close. And so we've seen this trend, instead of having increased access to services for people, there's been a move by conservative governments across the provinces to try to close sites. And here I just want to pause that one of the issues as well that's happening is that when sites and when services are closed, there's a lot of rhetoric around, oh, we're going to fund more treatment and more treatment beds, but treatment beds are not a magic panacea. They don't on their own actually, they're not very fast to actually put into place, number one. But the other thing is that treatment is a bit of a slow moving intervention. If you've got somebody in treatment who goes into treatment and then is in treatment for, let's say, 6 months, that's 6 months where another person can't be coming into their treatment bed. And so there's been a lot of rhetoric around increasing the number of treatment beds, but not. Again, we've never, ever had an increase in a way that would address the scale of the crisis that we're having, or in places where services have been closed, have there been any kind of increases in treatment that would, in treatment availability to actually address the closure of harm reduction services. There have also been increasingly lawsuits, class action lawsuits to try to close supervised consumption sites. First one in Vancouver earlier this year, as well as one has now been filed in Toronto to try to close one of the sites there. And there's been quite a bit of a backlash focused particularly in one national newspaper. And this is against one of the sites in Toronto that I'm quite familiar with their work. And they've actually been posting very, very disturbing photos of people, identifiable photos of people, and in ways that is very, very disturbing and doesn't respect people's privacy or access to health services. The photo on the right, I actually know the woman who is in this photo, whose photo was used here without her permission, as she was sitting on a bench right in front of the in front of the community health center. She was absolutely devastated by the posting of this photo in a national newspaper. And so I also think that we need to be thinking through, and there needs to be conversations around the methods being used to try to create public disapproval of these sites and the people who are being harmed as that happens. So just really, really quickly to finish off, there's been a lot of focus on harm reduction interventions, supervised consumption sites, safer supply programs, which I didn't get a chance to talk about today. But what I would put forward is that much of what we're actually seeing right now in terms of the crisis is that we're not actually focusing on all of the different factors that are resulting in the social and drug use problems that we're seeing. We're in fact using drug use and harm reduction programs as scapegoats for what are very complex social problems. We're not talking about the way in which our social welfare system has been systematically dismantled through austerity agendas over the last 20 years, how this has led to increasing poverty, economic inequality, and a lot of inflation and increases in the cost of living across the country. The major issue as well that we're not talking about is the massive affordable housing crisis, and how there has been massive increases in the amount of people experiencing homelessness, and that we've been conflating these two issues. People are seeing more and more people on the streets experiencing homelessness, and are conflating that with the toxic drug crisis. And I think that is a mistake, and it's going to distract from actually putting attention into addressing the housing crisis and ensuring that everybody has access to affordable housing, which is increasingly becoming more difficult. just in terms of the current state of supervised consumption sites across the country, in the Atlantic Canada region. Oh, sorry, there's actually 2 sites in Nova Scotia. I should have updated that. There's one in Halifax as well as one in Sydney. There's 1 site in New Brunswick. There's 4 in Quebec, several in Ontario, and in BC, as well as 1 site operating in Manitoba, 2 in Saskatchewan that are operating with no funding, and have been doing so by prairie harm reduction for several years now without funding. Alberta has seen actually a regression with several sites closing. And there is also a site in the Northern Territories in Yukon. And so what do we need to do? I'm just going to finish off really quickly with kind of a comprehensive look at what are some of the factors or some of the things that might be helpful alongside harm reduction interventions, like supervised consumption sites, which again have a huge evidence base for them, but have seen a huge amount of contention. We need to think about decriminalization and the way that criminalizing substance use has actually been leading to health harms. And again, there's a substantial research evidence for this that I'm happy to talk about if people have questions. We also need to focus on social determinants of health, in particular, making sure people have access to adequate housing and income supports, as well as addressing the history and continuing experience of racism and colonialization in Canada and in Canadian institutions, particularly for people who are First Nations, Métis, or Inuit. Increased access to harm reduction programs. We saw the modeling early on that showed the impact of naloxone distribution and harm reduction measures, as well as ensuring that there's easy access to opioid agonist treatment, which is the gold standard evidence-based treatment for opioid use disorder. And safer supply programs are one of the innovative new options. Opioid agonist treatment is very, very effective for the people for whom it works for, but unfortunately we see low retention over time. And safer supply is one of the ways to actually help people who have not been able to be retained or had success with opioid agonist treatments, to provide them with an increased number of options available when it comes to medication-based treatment options. And so with that, I'm going to, I was going to stop. So just basically all, 2 quick takeaways. All of our harm reduction interventions have actually faced backlash. So this goes back to needle and syringe programs, which have been a WHO approved and priority intervention to address HIV since the 1980s. Methadone programs, which is our primary opioid agonist treatment, also had huge backlash. What we really need is a continuum of different services necessary. Harm reduction and treatment aren't actually in opposition to each other. They never have been, and we don't have enough of either of them. And so we really need to ensure that we're increasing access to all the different forms of evidence-based interventions that can be effective to help and support people. And we also need to acknowledge that stigma, discrimination, and politicization of the overdose crisis are impeding the response. And take lessons from COVID, where we saw that we can mobilize to fight a major public health threat. And that is the end of my slides. I put my email address up there, knowing that it was going to be quick today to get through all of this, but feel free to get in touch. And if you have any questions, you can send questions to me at that email address. And I think there might also be a question in the chat that I'm going to try to get at. Right here. Oh, here we go. And so please feel free to send me an email if you want to. Also feel free to put any questions in the chat or put your hand up and we can answer them there. And I can see the chat now. It says, Dr. Kolla, it seems injection sites promote from your presentation to reduce harm. I wonder if there is addiction drug treatment and helping quitting centers to be increased in each site of an injection center. Yes, that's a very, very good question. Thank you so much for that. So yes, and I think I got to this at the end, and I probably should have made this point more clearly at the beginning. There's often this attempt to put harm reduction and treatment in opposition to each other. But in fact, as your question alludes to, they work very well together. So harm reduction is actually, and we have very strong evidence for this, people who access harm reduction services actually have an increased likelihood to go towards addiction treatment programs. And it makes a lot of sense, actually. If you are struggling with your substance use, you're going to a harm reduction program to receive support, and then you decide that you would like to go into treatment, you talk to the people at your harm reduction program, the professionals who are there, the workers, and they are the ones who have all the referrals, who know where to help you, to help support you to get treatment. In fact, in the research that we've done with supervised consumption sites, staff there talk about how they spend a lot of their time actually trying to find space in addiction treatment centers for people who would like it. The biggest problem that they face, and that people who are seeking addiction treatment face as well, is a lack of spaces. Overwhelmingly, the thing that we hear in all of the research, both the harm reduction and the treatment research, is that there's not enough spaces within treatment, either the medication-based treatment or residential treatment options. In fact, in Toronto, at the time that I was doing one of the studies on supervised consumption sites, and we asked staff about this, they were actually saying that the biggest issue they faced is they would be calling for a withdrawal management residential treatment bed for men. And when you called the central referral number, the message literally said, if you are calling for a bed for a man in the city of Toronto, please do not leave a message. There is no capacity. There is no wait list. They did have space for women, but there wasn't even actually any space and any ability to even leave a message to get on a wait list, because the services for men were so overburdened. And so we really do need to focus on access to treatment. That is 100% necessary. But the two of them need to work together. And harm reduction services are a great place for people to actually get access to addiction treatment when they want it and when they need it. And I'm just going to stop that now so we can see. Oh, there's a second question. Please keep them coming. We've got a few minutes left. From Stephanie, what are your thoughts on the Vancouver rolling back the decriminalization policy? Was it because the treatment options could not keep up with demand? Stephanie, that's also a very, very good question. I've done a little bit of a look into this. So the Vancouver rollback on decriminalization was actually focused specifically on public drug use. And if you go back, and I was actually part of the working group in Toronto that was looking at decriminalization in Toronto as well. When we were doing the working groups, and both Toronto and British Columbia had very, very comprehensive working groups to inform their decriminalization models and their decriminalization policies, the issue of public drug use wasn't on people's radars. And in fact, in Canada, we have no laws on public drug use. In Canada, we have laws on the possession of substances that are criminalized. So you basically have to be in possession of a drug. If you have used all of your drug, even in a public place, and there is no drug left on you, then you can't actually be arrested in Canada currently. Before decriminalization, or now after decriminalization, although that's changed a little bit, and I'll tell you how. And so it's interesting because the question of public drug use wasn't actually on the radar, simply because in Canada, the criminal law has always focused on possession rather than the space where you're using it. And so this was something that kind of a little bit came out of nowhere. And when I was talking about the increase in the affordable housing crisis and the increase in homelessness and the increase in particular of the visibility of homelessness, I think that what we're actually seeing in Vancouver and in British Columbia is a reaction to the increased visibility of our neighbors who are going through incredibly difficult times. Nobody wants to see somebody who's clearly unwell, who's clearly living on the street, who's clearly going through a difficult time. And that is actually really, really troubling for people. And I think that that's been at the crux of the issue, because if you look at the police data, and in fact, the police have said this in the British Columbia context, they actually did not see an increased number in complaints or arrests for public drug use in the period leading up to the rollback of decriminalization. And so I think this is a prime example of us conflating two social issues that we need to be dealing with separately. Is the toxic drug crisis a big issue? Yes. Is it difficult for folks to see people using drugs in public? Does anybody want that? No. Is homelessness and the affordable housing crisis getting to be crisis points in Canada? Yes. And I think that that's actually the issue that we need to be focusing on. If we were to deal with that issue, we'd see a lot less public drug use and a lot less of what people consider or think might be public drug use, which might just be somebody having a mental health crisis in a public place because they've been sleeping on a bench for the last 2 weeks and haven't been able to actually shower or have any of their basic hygiene needs met. And so again, I think that we need to be really, really careful right now. We're seeing a massive social crisis around housing, and it's being blamed on the toxic drug crisis when those are both crises and they both need to be addressed. But if we conflate them too much, we're going to actually not do a good job of addressing either of them. Okay, next question. I read about opinions that reinsurance with mandatory drug rehabilitation programs have higher drug use rates. Is that true? If it is, why? So there's some truth to that and there's some untruth to that. That's a very good question as well. Some places with mandatory drug treatment have higher rates of drug use. Some of them have lower rates of drug use. There's a lot of variation here. There's probably a lot of cultural factors, a lot of factors around availability of drugs that actually are playing in the mix as well. One thing I'll say about mandatory treatment, and we're going out of time and I want to get to all the questions. One thing about mandatory or forced treatment is that it has a very low success rate. So as a general rule, voluntary treatment where people make the decision themselves to go to treatment has a much higher success rate than any form of mandatory or forced treatment. That tends to have a very low success rate. And once people come out of mandatory treatment, they tend to return to drug use very quickly, primarily because they didn't want to be there or stopping their drug use in the first place. And so what I would often say whenever we get into this debate about should we be forcing people into treatment, should there be mandatory treatment? Well, let's increase the supply of voluntary, high quality treatment first and make sure that everybody who wants to go to treatment can immediately go to treatment when they want it. Let's do that part first. And then we'll talk about mandatory treatment, because the countries that have good supplies of high quality, evidence-based voluntary treatment tend to actually not need mandatory treatment very much, because people who want treatment can just go and access it. So I think sometimes it's a little bit of a red herring, and we just need to focus on, let's just get really good, high quality voluntary treatment in place in the first place. And then when it comes to our communities, next question, how do we think as community members we can better support harm reduction or substance use initiatives? Oh, that's a very, very kind question. And I really appreciate it, Lisa, because I think right now there's been so much contention and so much negativity around harm reduction and substance use that I really appreciate the idea of how do we actually support. I think that one of the main things right now is to remember that most people who are in problematic patterns of substance use aren't choosing that. And so I would say right now, I think that one of the most important things is to remember that we don't actually need to put concepts in opposition. We don't need to do, treatment or harm reduction. We need both, and we need a little bit of everything right now, and we need a lot of it. And I think that it's about talking to politicians and other community members about how caring for people. And again, like I was just saying, making sure that we have a good supply of high quality evidence-based treatment for everybody who wants it, because we don't have that in a single place in Canada right now. And so we need that alongside harm reduction, and talk about how we can support a continuum of options for people. Dr. Kolla, so next question, Dr. Kolla, conservative leader Pierre Poilievre once said, paid activists and public health bureaucrats whose jobs depend on the opioid crisis continuing are pushing the safe supply narrative. How do you comment his argument? Actually, that's a very interesting comment. He also had put in there, what was it? It was a comment about academics as well. It was something about ivory towered academics. And he was actually talking about me and my colleagues and the research that we're currently doing on safe supply, because I've published a good amount of the research on safe supply in Canada. This is just quite simply false. And as somebody who has put my heart and soul into trying to increase access to evidence-based treatment and harm reduction for people who use drugs and people who are dying in high numbers for a lot longer than this has been on Pierre Poilievre's radar, I think that we need to actually get back and get away from trying to do little sound bites about things. There is no one who is getting paid a lot of money to be doing this work. And there is no one who likes spending their time planning funerals, which is what a lot of folks who are actually doing this work are doing these days. The toll of death and loss in our communities from the overdose crisis has been absolutely astonishing. In fact, a whole segment of my research is on the level of burnout and trauma that's being faced by harm reduction workers and by people working to address the overdose crisis, from having lost so many of their community members, by having been to so many funerals, by having so many people who we work with die. And so, to be quite frank, I don't think that Pierre Poilievre has actually talked to any of the people on the front lines, because he would see the grief and the loss that people have suffered. And I don't think he would be quite so callous to say this. Nobody wants the overdose crisis to be continuing. Absolutely nobody. It has been awful and devastating. And yeah, I think that's about the only thing I can say about that. The next question, and I'm a little bit over time. Please feel free to go if you need to. I'm just going to answer. There's two last questions out here, so I'm just going to answer those really quickly. I'm curious about Portugal's approach to decriminalization. Didn't they have treatment that was mandatory, not necessarily rehab, but can be OAT? How can we increase motivation for folks to see treatment? Another great question. So Portugal, when they decriminalized, they actually, one of the things that they did do, and this was definitely a step in the right direction, was they put a lot of money into increasing the availability of treatment options for people. And the primary treatment option that they actually increased access to was opioid agonist treatment in Portugal. In fact, they have buses in Portugal that go around and deliver methadone, the primary OAT medication, to people in different areas of cities. So they made it really easy and low barrier to get onto medication to treat opioid use disorder. And they also increased the number of spaces for inpatient treatment. So that was a definite plus. And that is, as I've mentioned already, something we should be doing in Canada as well. They also, they didn't have treatment be mandatory. What they did was, for people who who were stopped with drugs, in possession of drugs in Portugal, they had to go to what they call a committee of dissuasion, which was generally one social worker and another worker. And so it wasn't a criminal process, it wasn't a police process, but you did actually have to meet with people about your substance use. Oftentimes, if it was a first time that you were going to the committee of dissuasion, they wouldn't do much of anything except provide you with education and resources. But if people were being seen by the committee of dissuasion multiple times, then they would actually be able to provide more treatment options to people, including more of the not mandatory treatment, but they would actually provide, they would give people the option of doing treatment or then actually going to prison. And so, which isn't mandatory, but it's a choice that a lot of people, you can guess which direction most people go in that case. And so I think that that's one of the ways that often people have said, okay, well, this is actually mandatory treatment. That was the thing that worked. Again, they did that for a very small group of people. The main thing they did was they increased the availability of high quality treatment for anybody who wanted it when they wanted it. And so for your second part of your question, how can we increase motivation for folks to seek treatment? Well, quite simply, we can make it available to people, because the biggest problem we're having right now for folks who want treatment is they cannot get access to it when they want it because it's not available. We have a major capacity issue. And so that capacity issue is the one that has to be addressed first. And then for the small number of people who might need other options, then mandatory treatment, that becomes a conversation. But again, I think that that's a little bit further down the road, and we just need to increase access to evidence-based treatment in the first place. And last question. I work in maternal care and would like to know if there's a priority for female people who are using drugs in any injection site or addiction treatment when they're seeking help. Will you see if gender priority injection center or drug treatment center in the future? That's a really, really great question. So yes, there tend to be, and again, this varies a lot by jurisdiction. This is a very good question. There tends to be in different jurisdictions programs for people who are pregnant to get them into maternity care and to get them access to OAT. Again, methadone as an opioid agonist treatment is the evidence-based option for people in maternity care and can be done very, very safely for both mom and baby. And so there is quite a few programs in different places to ensure access for that. We do in some places see addiction treatment centers that are more focused on women and on their needs. And you generally do tend to see a few more spaces available for women. But again, this is very much still a major capacity issue. The question about gender or women priority injection, supervised injection sites. Interestingly, there are a couple sites like that. There is one in Vancouver that is a women's only site or a site for women and gender diverse people. You also have women's only hours at certain supervised consumption sites across the country. And different sites have had success at getting women in. In fact, I did an evaluation of a site in Toronto at an organization called Street House that was a very small site. It was very homey. All of the staff were women or gender diverse people, and they actually had the highest participation rate among women. It was over 60% of all of the people accessing their services were actually women. And so I think that there's some ways that we can actually increase the accessibility and the willingness of women to use sites, and that are not just about gender specific sites, but you definitely do see gender specific sites and treatment programs at different places across the country. I went a little bit over. I apologize for that, but these were very, very great questions, and so I hope you don't mind that I took a bit of extra time to answer them. But if there's any other questions, please do feel free to send me an email. And I think that would about wrap us up.
Okay, actually, before we end our seminar, I just wanted to hop on quickly again to say thank you, Dr. Kolla, for the amount of time and effort you put into your talk tonight. I think it was a very insightful and thought-provoking presentation. The depth of knowledge you've shared regarding these public health issues and practical approaches such as the supervised consumption sites is incredibly valuable. And I think your commitment to understanding and addressing these challenges is not only impactful, but truly inspiring. So thank you very much for that.
Okay, Gillian, thank you very much. For the excellent presentation. Thank you.
Thank you so much, Lisa, and thank you, Peter, for having me. I very, very much appreciated being here tonight.